Assalamu alaikum. كيف حالكم? Can you hear me? So I'm happy to be back in the Kingdom of Saudi Arabia, back because I'm glad to report that I actually began my medical career in Saudi Arabia. Soon after graduation, I was working for Ministry of Health in Asir province, in the lovely mountain town of Al Namas, if anybody is from there, and a valley village called Behban, where I first encountered sail, or what's called flash flooding. So happy to come back here and give back to the community a little bit. All right, if we can have the slides. Can we have my slides? So we're going to talk about approach to respiratory failure in children today. This is a big topic, so I'm going to, as the title implies, I'm going to be talking about the approach. So I will not go into details about anything. Okay, so I have no financial relationships to disclose. I hope that following my presentation, you would be able to understand the definition, the pathophysiology, and signs of respiratory failure, recognize and manage respiratory failure, and outline various techniques of providing respiratory support. So what is respiratory failure? Any infant or child who presents in acute respiratory distress with either acute hypoxia requiring supplemental oxygen to maintain saturation more than 92%, or acute hypercardia with PCO2 of more than 50 is basically defined as having acute respiratory failure. What are the main causes? Upper airway obstruction like croup, epiglottitis, lower airway obstruction like bronchiolitis, status asthmaticus, lung tissue damage, parenchymal disease, that is pneumonia, pulmonary edema, or disordered control of breathing, that is hypoventilation, as happens following seizures, coma, muscle weakness. The key in respiratory failure management is early recognition. So watch for any signs of cyanosis on clinical examination, hypoxia. If the patient is on monitor, you want to watch for falling saturation of oxygen, increased work of breathing, and the worst case, developing apnea. So this slide is important because it shows us how a child is different from an adult, and within the child, the various patterns. So if you see in an adult, for the saturation, if suppose you stop the adult from breathing, it would take almost 10 minutes for a regular adult to come to a saturation of 0. Whereas in a normal 10-kilogram child, a 1-year-old child, this would happen within 4 minutes. And the other key thing is, for the saturation to drop from 100% to 95%, it will take almost 2-3 minutes. So the majority of the time till the full saturation drop happens for the saturation to drop from 100 to 95%. And after that, you can see the fall is very steep. Oops. All right, so this slide demonstrates the same thing. So time to 95%, you can see in 3 months to 1 year, it's pretty much the same, 2 minutes, but then from 95 to 95 to 90%, 8 seconds. So again, the importance of early recognition. Remember, respiratory arrest is the most common cause of cardiac arrest in children. In children, heart disease is very uncommon. So often the predisposing factor is respiratory arrest. And amongst patients with cardiopulmonary arrest, outcomes are worst for patients who develop this because of respiratory deterioration. This is the pediatric assessment triangle. Anytime we get a sick patient We should look at the appearance, the work of breathing, circulation, and manage accordingly. In terms of support, airway, so any child who comes with respiratory distress or concern for respiratory failure, provide 100% oxygen. Allow the child to assume a position of comfort. If needed, open the airway. Clear the airway as needed, and insertion of an artificial airway as needed. You want to put the patient on monitors, monitor oxygenation, monitor ventilation by end-tidal CO2 if that is available. More and more, we can do it even in patients who are not intubated. And then administer medications as needed. For example, if he has asthma, administer albuterol. If he has croup, administer epinephrine. And then if the preceding measures fail, then and the patient is getting into impending respiratory failure, then that becomes an indication for positive pressure ventilation, which would be started with bag valve mask or flow inflating device, like Anderson valves, to oxygenate and improve ventilation, and then endotracheal intubation. Now, what I'm going to be talking about much more in this lecture is about non-invasive ventilation. So selected patients with respiratory failure can often be managed with techniques that are considered under non-invasive ventilation before proceeding to invasive ventilation. These include CPAP, BiPAP, and then a related modality that many of the speakers have previously mentioned, high-frequency nasal cannula oxygen. What are the advantages of non-invasive ventilation? It has the ability to reduce work of breathing and improve gas exchange while avoiding the risks and complications related to ET tube. Remember, for intubation, you have to sedate the patient, you have to paralyze the patient so that the patient is apneic and not breathing on his own. So if you have difficulty intubating him, the patient can have complications, the patient may die. During the intubation, the tube can shift out, become displaced again, all the associated complications. So if we can avoid intubation and still provide help with the ventilation, that is very useful. Of course, we have to remember that non-invasive ventilation is not suited for patients in cardiopulmonary arrest, in patients who have acutely impaired mental status or the deteriorating mental status, those with high aspiration risk and need for airway protection. Bag valve ventilation, just in brief, you want to do the face mask sizing. Remember, in children, that is the disadvantage. You can't just use a standard face mask. There are two kinds of ventilation bags, self-inflating and flow-inflating. We have to become familiar with whatever modality we have in our emergency department. The bag size is 500 ml for infants and young children and 1000 ml for older children and adolescents. You have the 1 or 2% technique. You want a tight mask seal aiming for chest rise. That is the bottom line. And this is a good slide because remember, sometimes you wonder where to put the towel roll, under the shoulder, under the head, here, there. So the key thing is if you align the ear to the sternal notch, as long as you get that right, that is the position that you want for bag valve mask ventilation, intubation for any modality. Airway adjuncts are especially useful if there is concern for upper airway obstruction and if you're finding difficulty with ventilation with bag valve mask. You can use oropharyngeal airway if the patient is unconscious, or nasopharyngeal airway for conscious or semi-conscious patients. This is especially appropriate in patients who are post-ictal and may have mild hypoxia related to hypoventilation. Putting in a nasopharyngeal airway often improves the airway and brings the situation under control. Endotracheal intubation would be indicated if the child is unable to maintain effective airway oxygenation or ventilation despite the interventions that we discussed earlier. So again, like Mark had talked about, it's useful to divide intubation into pre-procedure preparation, which involves mainly hyperoxygenation, preparing equipment, the procedure itself, inserting the ET tube, and then post-procedure, confirming the tube position and securing the tube. Medications, just in brief, Vagolitec, like again, Mark implied, the use of atropine is debatable, and more we are giving up on it. Sedative, there are various sedatives, ketamine, etomidate. Those two are pretty much applicable across the board. Etomidate use is sort of not considered of choice in patients with sepsis. Paralytic neuromuscular blockade, most of the time in children, we prefer to use non-depolarizing agents like bacuronium, atricuronium. I just want to introduce this, it's been talked about CMAC video laryngoscope. That's the preferred laryngoscope in RED. It's a wonderful laryngoscope. We like it because you can use pretty much similar to, the blades are similar to what we use already, Macintosh blades or Miller blades, and you can see it on the screen. So there's a mentor or supervisor can see actually how the tube is going in. You don't have to stand behind the shoulder. You can see it on the image on the monitor. One thing that hasn't been discussed so far too much is the use of laryngeal mask airways. So why do we need laryngeal mask airways? So the guidance is that when back valve ventilation is unsuccessful and when ET tube is not possible for whatever reason, the LMA is the sort of airway rescue modality of choice. Not cricothyrotomy directly, but LMA. So this is what it looks like. Again, unfortunately, in children, as compared to adults, you have to size them. So their sizing is a little bit sort of less than ideally intuitive. I'm giving you some pictures. So this is the LMA sizing. So you need to be familiar with them and have them available along with your intubation supplies. It has to be available, if not outside the cart, at least the cart has to be available next to you when you are intubating any patient. Now we come to the non-invasive ventilation modalities. So one of the situations where we use high flow nasal canal oxygen is in bronchiolitis. And as you're aware, bronchiolitis is the clinical practice guideline that recently came up, has recommendations about mainly what not to use in bronchiolitis, right? We shouldn't use albuterol, we shouldn't use epinephrine, we shouldn't use steroids. What do? Nasal suction as needed, that's it. And then if the patient needs further support, that is when, our role comes in. If the patient is hypoxic, not working too hard, then we can use regular 1 to 2 liters per minute nasal canal oxygen. But as we see, most of the time, the problem with young infants with bronchiolitis is their increased work of breathing. And to help with that is high flow nasal canal oxygen. So, we have by now extensive NICU, PICU, PEDS floor literature on safe use of high flow nasal canal oxygen. These are the two main systems in use in the US, Vapotherm and Fisher-Paykel. So what is high flow nasal canal oxygen? This is a good mnemonic that tells you. So this is heated and humidified, as against traditional nasal canal oxygen, which is not heated, which is not humidified. So if you're using it for a prolonged time, heated and humidified gas is more easily tolerated. It matches the inspiratory demands. So 1 to 2 liter in a young infant is enough if they are breathing at tidal volume. But if they are breathing fast, they have a lot of inspiratory demand, then that 1 to 2 liter will be diluted and the FiO2 would be very low. So if you can give them high volumes, then that can meet their inspiratory demand. It increases functional residual capacity, likely via delivery of PEEP. So that is how one of the touted mechanisms of action. It's a much easier system than for CPAP and BiPAP. All you need is a little nasal cannula, so it's not heavy, it's very convenient. Patient can be fed along with using HFNC and wash out of dead space. So as you can see, on the left part of the graph, you can see the 1 liter per minute where the partial pressure is about 0, but if you use 7 liters per minute or high flow nasal canal oxygen, your partial pressure, or basically the PEEP, increases. And in terms of esophageal pressure, it reduces pressure swings, and that contributes to reducing the work of breathing. How much flow is enough? In infants, we tend to use 1.5 to 2 liters per kg per minute. We would often begin with 1.5 liter per kg per minute. And if there isn't a significant good response, then we would go up to a max of 2 liters per kg per minute. So bottom line, high flow nasal canal oxygen can be used as a supportive therapy. Remember that it does not have any effect on the disease course or on the length of stay. It mainly reduces symptoms. It reduces the distress, escalation, distress both for the infant as well as for the caregivers, the parents, and even the medical providers. It's safe to be used on inpatient floors, so which is very important. The patient does not have to be transferred to the ICU. And most hospitalized patients who are started on high flow nasal cannula oxygen do not require further escalation. So you can save lots of, especially from community hospitals prior to the use of high flow nasal cannula oxygen, we used to see lots of patients would be transferred to PICUs, but with the use, that transfer rate has gone down. So we would use it if there was no improvement with supportive care or suctioning. We initiate it at 1.5 to 2 liters per kg per minute, up to 20 liters per minute for infants. And another good thing is that once you realize that the infant is breathing well, you don't have to wean it like, from 20 liters to 15 to 10. You can just stop it, completely discontinue it when improved. The other advantage is, like I mentioned, the infant can continue to feed orally or NG if clinically stable, and it's suitable for use in community hospitals. So this would be an illustrative case. We got a 3-month-old girl with trouble breathing, typical bronchiolitis, diffuse wheeze, crackles, working hard at the breathing, improved with suctioning in the ED care, but had work of breathing enough that she was admitted for observation. On the second day of admission, she had further increased distress, initiated on high flow nasal cannula oxygen, discontinued after 24 hours, went home happy. Hey, my slides are not working again. Okay. The next modality I want to talk about is CPAP, or continuous positive airway pressure. So what are the uses of CPAP? What are the indications for CPAP? Acute hypercarbia or hypoxia for any reason, because remember, CPAP basically increases PEEP. So if you have hypoxia, if you have hypercarbia, in both of those instances, improving PEEP would help. And the clinical indications are bronchiolitis, asthma, hypoventilation related to obesity, or in any patient with pulmonary edema. Basically, you're applying extrinsic PEEP to offset the intrinsic PEEP. The constant airway pressure maintains gas exchange, stents the airway open, increases functional residual capacity, and improves alveolar recruitment. So this is a good slide that shows, that over time in the study, they found that as the use of non-invasive ventilation modalities increased, and this was mainly related to CPAP, the rate of intubation went down. So, lots of cases of intubation can be averted if these modalities are used in time. So bottom line, for bronchiolitis, we use CPAP as a supportive therapy. Again, similar to high flow, no effect on disease course, but it is associated with decreased intubation rates, lower failure in ICU level patients than with HFNC. So often our approach would be, if we had a patient with bronchiolitis with severe work of breathing, first we would use high flow nasal cannula oxygen up to 2 liters per kg per minute. And if the patient did not improve enough for that, then we would go to CPAP, or we would start, I think we would talk about it. Yeah, so we initiate it at 5 to 8 centimeters water, and then increase in, gradations of 1 to 2 per minute as needed. Close observation is required for patients on CPAP. In our system, we would admit any patient on CPAP to the ICU, and we do not allow PO feeding for these patients. And then the final modality in this triad of modalities is BiPAP. As you can see in BiPAP, you have the PEEP raised as well. And in addition, the peak inspiratory pressure also comes into play because that is also supported. So we are supporting inspiration and expiration both with pressures. So it has the same effects as CPAP, but also helps in inspiration. And the main indication for BiPAP is in patients with severe asthma, as again, the previous speakers pointed out. It does not replace standard therapy. Remember, it will only come into play if the standard therapy has not worked. And the standard therapy, just to recapitulate again, are bronchodilators. If the initial doses don't work, we add continuous albuterol, ipratropium, IV magnesium, steroids, and terbutaline or epinephrine, subcutaneous or IM. The use of BiPAP, again, is very helpful in reducing work of breathing, often in patients with impending respiratory failure. It may require anxiolysis. So in some patients tolerate BiPAP well, but some patients are sort of more anxious because BiPAP involves a bigger circuit, bigger mask, etc. So a mild dose of anxiolysis may be indicated and may be safe in these patients. It becomes contraindicated if the patient becomes obtunded, combative, or the mental status starts failing. That becomes an indication for intubation. Again, we initiate it at moderate settings at approximately 10 by 5 centimeters of water, and then you can gradually tailor it to the response. So this was a recent patient where we used it, 13-year-old with severe asthma exacerbation, developed sudden symptoms late at night, marked dyspnea despite maximal treatment. He was initiated on BiPAP 10 by 5. And the other advantage with BiPAP or CPAP is that you can continue using continuous albuterol as well. Our RTs can devise a system so that that can still continue. And he improved over the next 12 hours, and then at that stage was transferred to the floor, avoiding intubation. So to summarize for respiratory failure, the key thing is early recognition, like we said, because remember, it takes time for the saturation to drop from 100 to 95%, but after that, the drop can be precipitous if we've not rectified the cause of that fall in saturation. Infants deteriorate much more quicker than older children and adolescents, so we have to be extremely careful for them. You know, that general fear among adult emergency medicine physicians and even among PEM physicians to worry more about younger infants than for older children is completely legitimate, and respond to that. Rapid assessment and stabilization, consider use of non-invasive ventilation, and then if that is not successful, then going on to bag valve mask, intubation, or LMA. Thank you.